Hello everyone, I'm Dr. Neil Rathor and I'm doing my post graduation in internal medicine. And the purpose of making this video is again to simplify the content which is in the book because it can be really mind boggling to read it straight from the book. So, this is just to simplify it. Today, we'll be reading Acute Respiratory Distress Syndrome. Acute Respiratory Distress Syndrome (ARDS) is very important clinically as well as it is important for the exam purpose. So let's get started. ARDS is a clinical syndrome which comprises of three factors. The first one would be severe dyspnea of rapid onset. So rapid onset here means that the duration of dyspnea should be equal to less than 7 days. The second factor is hypoxemia. Hypoxemia is low oxygen in blood, and the third is diffuse pulmonary infiltrates, which leads to respiratory failure. So pulmonary infiltrates will be seen in chest x-ray. The etiology will be divided into direct lung injury and indirect lung injury. So I have enumerated a few causes which causes direct lung injury and indirect lung injury. The most important cause indirect is pneumonia. The second is aspiration of gastric contents, pulmonary contusion, near drowning, and toxic inhalation injury. But the most common is pneumonia, and in indirect causes, the most common is sepsis. So pneumonia and sepsis, they both contribute to up to 40 to 60% of cases of ARDS. So it is very important to see if a patient has come with pneumonia, signs and symptoms of pneumonia, or signs and symptoms of sepsis, the patient may land up in ARDS. The other important causes of indirect lung injury are severe trauma like multiple bone fractures, flail chest, head trauma, burns, or like multiple transfusions during a short period of time, drug overdose, pancreatitis, and post cardiopulmonary bypass. Though these are the rare causes, but we need to keep them in mind because they might cause ARDS eventually. There is no need to mug up the entire table. You can remember the important causes like pneumonia and sepsis, and the others are just do one reading and that's fine. Next up, we'll be reading the diagnostic criteria of ARDS. So there are four important factors which will eventually make a diagnosis of ARDS. The first one is the severity, the oxygenation. So the oxygenation is divided into, the severity is divided into three categories: mild, moderate, and severe. The numbers we need to remember is here are, the mild would be the ratio of PaO2 by FiO2. So PaO2 is arterial partial pressure of oxygen and FiO2 is inspired O2 percentage. So the ratio of PaO2 by FiO2 should be between 200 to 300 in mild, between 100 to 200 in moderate, and it will be less than 100 in severe cases. So the numbers are like 200 to 300, 100 to 200, and less than 100. The next is the onset. The onset should be acute. It should be within 1 week of the clinical insult. In short, the dyspnea should be of 1 week. Next up is the chest x-ray. The chest x-ray will show bilateral opacities which are consistent with pulmonary edema, but they are not explained by the other causes like effusion, lobar, or lung collapse or nodules. So we need to rule out all other things which are causing the bilateral infiltrates. And this is the x-ray which shows diffused pulmonary infiltrates in bilateral lungs. And the next criteria is absence of LA hypertension. It is very important to rule out that the cause of the pulmonary edema is not related to the heart. So it should not be cardiogenic, but it should be non-cardiogenic pulmonary edema. So there are three important phases by which ARDS progresses. The first is exudative, where there is damage to the alveolar capillary endothelial cells and type 1 pneumocytes जो barrier बना होता है around the alveoli it breaks. So there is loss of barrier, which leads to accumulation of fluid in interstitial and alveolar spaces, which leads to decreased lung compliance. जब edema हो गया है तो lung is not able to expand like it used to, which which may further develop hypoxemia in patient, which is decreased oxygen in blood, leading to increased work of breathing and eventually dyspnea. So this exudative phase lasts for first 7 days of illness after the exposure. Hence, 1 to 7 days is exudative phase, next is proliferative phase, and the third one is fibrotic phase. Now, approximately after 3 weeks of injury, most patients recover, but those who doesn't, these patients enter into the fibrotic phase. But before fibrotic phase, there is proliferative phase. So the second phase of ARDS is proliferative phase. The duration of proliferative phase is 7 to 21 days. So for 1 to 7 was fibrotic, sorry, 1 to 7 was exudative. Now 7 to 21 is proliferative phase. So mostly patients recover rapidly and are liberated from the mechanical ventilation during this phase. But some patients develop progressive lung injury and early changes of pulmonary fibrosis during the proliferative phase. So usually there is initiation of lung repair, which when there was exudative phase, where they shift from neutrophil to lymphocyte predominant pulmonary infiltrates. The next phase, the third phase, is fibrotic phase. So some patients may enter fibrotic phase, where the patients may require long-term support on mechanical ventilation and or supplemental oxygen. So there's alveolar edema. Then there is extensive alveolar duct and interstitial fibrosis, which can lead to emphysema-like changes, like with large bullae. And then there is progressive vascular occlusion and pulmonary hypertension. And if we get a lung biopsy done, there'll be fibrosis seen. So this is all we can see in fibrotic phase. Fibrosis starts. So it is really worrisome when a patient enters into fibrotic phase, because then patient has become dependent and it's usually requiring a mechanical ventilation for a long period of time. So there's tachypnea, which leads to increased work of breathing, which leads to respiratory fatigue and eventually respiratory failure. So that's how the cycle goes. Now, if we see from day 0 to day 21, from 0 to 2, there'll be edema, like we saw in exudative phase. Then there's development of hyaline membrane, which is also seen in exudative phase. From 7 to 14, there will be, from 7 to 21, there'll be proliferative phase where there'll be interstitial inflammation. And from 21, eventually there'll be fibrotic phase when the lung starts fibrosing. Now, let us look at the important differential diagnosis when it comes to ARDS. The other important DDs would be cardiogenic pulmonary edema, bilateral pneumonia, and alveolar hemorrhage. These are the common, but the less common DDs would be acute interstitial lung disease, hypersensitivity pneumonitis, toxin injury, and neurogenic pulmonary edema. Now, let us move on to the very important part about treating the patient, because ARDS can quickly progress, so we need to immediately start the treatment. The first would be by recognizing and treating the underlying cause, whether it's pneumonia or sepsis or the rare causes which we saw earlier. Next up, we'll be seeing the management, that how will we start the mechanical ventilation. So we do not want to cause a volume trauma or barotrauma to the alveoli. So we'll give low tidal volume. The low tidal volume 6 ml per kg, minimizing the LA filling pressure. Now high PEEP or open lung. Prone positioning have seen to be very, very helpful in patients with ARDS. High frequency ventilation, ECMO, extracorporeal, inhaled epoprostenol, and surfactant replacements, and other anti-inflammatory therapy like PGE1 and NSAIDs may be of some help. So we will initiate by giving volume and pressure limited ventilation, because it is very important to give low tidal volume. So by giving volume and pressure limited ventilation, we will oxygenate the patient, and the values to be remembered is tidal volume of less than 6 ml per kg of predicted body weight, plateau pressure of less than 30 centimeter of H2O, and respiratory rate to be maintained below 35 beats per minute. The settings would be FiO2 less than 0.6 and SpO2 to be maintained between 88 to 95%. We will try and minimize the acidosis, so we'll keep the pH between I'll keep the pH more than equal to 7.3. Respiratory rate again less than 35 beats per minute, and we'll try and initiate diuresis. So we'll try and keep the map of the patient more than 65 mmHg, and that's it. A big thank you for watching this. Keep supporting.